Hi, I'm Dr. Ben LaHood, cataract and refractive surgeon. Welcome to this digital learning series. I'm going to be talking today about the decision-making process with a toric IOL, whether to rotate or whether to exchange the lens. It's always a difficult decision, so I'm going to be giving some pointers on how you can make that decision and what information you'll need. So I think this is the key point of the whole presentation, is that this is a Venn diagram of happy patients and where you've got the IOL in the correct position. It's going to be most of your patients will lie in the middle where they're happy and the lens is in the right place. Now you've got a small amount of people who the lens isn't in exactly the right rotation, might not be the exact right power, but they're happy. Don't touch those patients, they're great, leave them alone. The point of this is the people that are unhappy and the lens is not in the right position, what do you do with them? How do you make that decision? And I'll be talking you through that process. So what you will need, first of all, you're going to need a patient with a toric IOL in their eye and a refractive error. You're going to need a very accurate subjective refraction. All of your information for what you're going to do comes from the subjective refraction, so this should be your absolute priority, getting a very accurate refraction. Not an automated refraction, not a wavefront refraction, but a subjective refraction where the patient tells you what they want, because that takes into account their eye, their brain, everything about it. You're going to know what the IOL is in terms of its power, its sphere power, its cylinder power, and you want to know where it is in the eye. So you'll need to know its axis, where it is sitting, not where you plan, but where it truly is sitting, and its depth, so the AC depth of the eye. What you don't need, but I would recommend checking, would be repeating the keratometry. Also repeating the axial length. The main reason for this is to think, why have I got an error? Have I used the right biometry? Has something gone wrong? It's very unlikely, and you're not going to need this information to fix the problem, but you will want it to know why this went wrong. You also want to check that you put the right IOL into the right eye. You might have to go back to the theatre records for that, or the notes. Now, why did this happen? First of all, it doesn't particularly matter why, we can fix it. That's the most important thing. If you've got an error with your spherical equivalent, so if you add up your spherical equivalent for this eye and you get close to 0, that can be a rotational problem. If you've got a large spherical equivalent error, -1, -2, +1, then that's not going to be helped by rotating the lens. That is that the lens is either not sitting in the right position in terms of depth, and you've got a spherical error. If you've got the axis that's planned, but you've still got an astigmatic error, then you have to think, did you use the incorrect or poor biometry? It's a very common reason, and I'm not saying it's the wrong patient, but maybe you had a dry eye, maybe this just wasn't particularly accurate biometry on the day. Possibly the SIA, so the surgically induced astigmatism, was larger or abnormal. We know that we used to be taught that when you cut a cornea, that causes a flattening effect exactly where you cut, but we now have much better idea that that flattening effect can happen anywhere around the circumference of the eye. So that could be what's happened. You could have had an unaccounted for, unusual posterior corneal astigmatism, or you may have just not incorporated that into your calculation. The IOL itself could be significantly tilted or decentered. Generally with a monofocal lens, a little bit of decentration doesn't have a huge effect, but tilt can be significant. Now, when IOLs are made, they do have a tolerance. For low-powered lenses, usually if you put in a 20 diopter lens, it should be within 20 to 20.2, 20.3. If you're putting in a much stronger lens, like a 30 diopter lens, that tolerance can go up very high. You might be thinking you put in a 30, but it could be a 30.8, anywhere up to almost a 31. So that can be quite an issue for a strong lens and a short eye. And ultimately, the other thing that can go wrong and does go wrong is putting in the wrong IOL. It's not the end of the world, but it does happen. If your axis is incorrect and you have an astigmatic error, then you've probably got an early post-operative rotation, and that's all that's happened. So what's the next step? Realistically, after you've gathered that information, unless you're some kind of mathematician, you're going to need some help. And the three options I've put up there are Toric Pro, which I have something to do with, and that's my preference, Astigmatism Fix, which is a well-known website, and the Barrett RX formula. That's part of the Barrett Universal Suite, and that gives you both a spherical and an astigmatic correction fix for both of them, whereas the first two will just give you an astigmatic error. First of all, Toric Pro. This is currently a website and soon to be an app, and I've just filmed a screenshot of how this works. But basically, put in some demographic information, which eye you're using, name of the patient for your own identification, put in the lens that you've used and the current refractive error for that eye, because that's all the information you really need to know what to do with this lens. You want to work in your sphere and SIL powers, keep it very simple. You need to know the current location of where the lens is, and so that at the slit lamp you can measure the axis of where the lens is, and in terms of its depth you can use that from biometry. So if you put that patient back on a biometer, you could measure their pseudophakic AC depth. In terms of the back vertex distance with your refraction, if you don't have a measurement for that, we just have a standard 12.5 millimeters. Now this will give you an outcome. It'll tell you what the current lens is in the eye and its position, as well as the optimal position and power of that cylinder. After that, we give some very basic recommendations in terms of this lens would benefit from rotation, or this would probably benefit more from exchange, but that really comes down to you. The problem is, if the power of the cylinder that's recommended is significantly different to the power that's in there, no matter how much you rotate that lens, you won't fix the refractive error. Now if that difference is closer to the next step of toric steps in that lens preference, then you know that potentially you could exchange the lens and put the next toric power in. Now this won't tell you exactly which lens you'll change to, because different manufacturers of lenses use different strengths of toric steps, but in general most people stick to one particular type of toric, and you'll know what the next step is, and you'll be able to work out whether it's closer to that next step or the one that's currently in there. Astigmatism Fix is the other option that I recommend. It's made by John Berdal and it's called the Toric Results Analyzer. It's a very common method, and I've again just got a video run through of my screen just showing how to use it. But it's also very straightforward. Some demographic data, you can actually choose the lens rather than putting in the SIL and sphere power. They've got a selection of lenses. Now you do have to be a little bit careful, because you do have to enter the power of things in the corneal plane, and that does take just a little bit of maths to convert, and so that's why I prefer Toric Pro, it's just because there's none of that conversion. But overall, same idea. This will then give you a recommendation about the optimal position of the lens where it should be, and again it will tell you if it thinks that an IOL exchange would be a better option. So again, a really simple method, but it's not something you can do by yourself. The third option is the Barrett RX, and I think most surgeons are used to the Barrett formula, most used to the Barrett Toric calculator and the general layout. So Barrett RX, the benefit of this will be, if you do have a significant spherical equivalent error, this will actually be able to tell you, should you exchange the lens in terms of sphere power as well as cylinder power. The two options so far have just been talking about astigmatic error and cylinder power. This will also talk about spherical error and sphere power. So again, just a screenshot run through with this one. And again, just putting in demographic data, filling in all the fields about what you currently have. You do have to describe what lens you would exchange to if an exchange is recommended. And that should be pretty straightforward. And then, as with all Barrett calculators, you do have to click Calculate before you go to the next step. So I've hit Calculate there, moving on to the next step, and it will give us some outcomes. So this will tell us whether the sphere and SIL power need changing and what the optimal location will be, as well as the expected refractive outcome. So a huge amount of information, a little bit more complicated in terms of what you need. You will need some new biometry for this method, but you know, a very powerful tool. So In terms of decision making, my tips are if you've got a significant spherical equivalent error, that's not going to be solved by rotating the toric IOL, no matter where you put it. Consider which toric IOLs you're comfortable using, because those steps will decide whether exchange is possible or beneficial. So always think, this is my current lens and this is the cell power, this is the next cell power. If the recommended lens is more than halfway to the next power, then basically an exchange is warranted. It's as simple as that. And also, this is my final tip, would be don't simply go back in and rotate the lens to your original plan. Everything has changed. You've made an incision in the cornea, you've got the lens sitting where you want it now, you know the effective lens position. You need to be guided by that subjective refraction. I really can't push that enough. Subjective refraction is everything, and don't consider your original plan again. And just a final reminder, it's not the end of the world if you've got an astigmatic refractive error. We still have a few other things up our sleeve apart from rotating and exchanging lenses, because I know not everyone's comfortable with that. Glasses are okay, I hate saying that, but they are. Supplementary IOLs in the sulcus can solve a lot of issues. And finally, laser vision correction is excellent. So thank you very much for watching. I hope you enjoyed that. And again, I've talked about quite a complicated area. So if you do have any questions at all, I'm always happy to answer them. Thank you very much.